Good evening. You are watching PBS 39, and I'm your host, Tony Kayumi. This is Healthline Women's Health. Our topic of conversation this evening are the medical advances in hysterectomies, and our guest expert is Dr. Jeffrey Cly. He's here to answer any questions that you might have about the above-mentioned topic. Very easy to participate in the show. Just dial the number that you see on the screen at any time throughout tonight's program. I want to thank you so much for joining us.
Thank you very much.
Could you start out the program by telling us what a hysterectomy is?
Sure. A hysterectomy is removal of a uterus, and it refers mainly to the uterus. A lot of people think it also includes the ovaries, but that is actually separate. So when we're talking hysterectomy, we're talking uterus only, and that's important because keeping the ovaries in many patients allows them to keep their own natural hormones. And
some of the reasons that women might be receiving a hysterectomy?
Especially after trying first conservative therapies where a hysterectomy is not necessary. If those fail, then a hysterectomy could be necessary for persistent bleeding, cramps, pain, fibroids, which are growths in the uterus, even sometimes prolapse, cancer, and hopefully that's a rarity.
Can you tell us about how hysterectomies used to be performed and are still currently being performed, and then compare that to the advances that are available now?
Sure. And this is kind of all a new change, and medicine always changes as technology advances. And when I started in medical school in the 90s, that's when the laparoscopic gallbladders and laparoscopic appendixes were starting to be done. And that kind of changed those surgeries from an open procedure, big incision, a lot of pain, a lot of time off, into an outpatient procedure, minimal pain, minimal time off. And we're seeing the same thing happen with hysterectomy. And it started with the open hysterectomy, which is a large incision, 6 weeks off of work, 2 weeks no driving. And to now we have a Da Vinci system that is a robotic type of a hysterectomy where I still control the instruments, but they're only millimeters big. And the patient goes home in 3 hours and is back to work or normal at 3 to 7 days with minimal pain, minimal discomfort. And so we've really revolutionized the women's care for surgery, getting them back to life faster.
And I know we have some video footage of the procedure using the Da Vinci system that you've been speaking of.
Yes, the Da Vinci is available here in town, and we're looking at it right now on the screen. And I sit on the left, and I'm able to operate through that console, and it's a three-dimensional console. And on the right, I've already set those small instruments inside the patient in a laparoscopic type of a fashion, and those are only 7 millimeters diameter, and the instrument tips are 2 to 3 millimeters. And so whenever I move my hand, you'll see like that instrument's moving. It opens, closes, it twists like a wrist. So I'm able to get inside near the uterus and operate on the blood vessels and actually stop bleeding before it happens, or remove the uterus with very minimal disruption of the tissue, and that's why it causes very little pain. And you can see that when I move my hands, like in that last little video, it moves inside. And the tips are 2 millimeters across, just almost microscopic. And so it gives me a high definition, otherwise I wouldn't even be able to see that well. It's so small.
Now, who makes a good candidate for this type of surgery?
Everybody's a candidate for the surgery. We're finding, though, that it's best utilized because of we only have 2 of those in town, for people who would have to have an open hysterectomy and a large incision. A lot of people could have a vaginal hysterectomy or a laparoscopic hysterectomy, and without the Da Vinci, and I would continue to recommend them to have that. But if a doctor is saying, I've got to open you up, I've got to make that big C-section incision, those are the people that should raise their hand and say, hold on, I'd like that Da Vinci system. I heard I could have that, not be cut wide open, and I could get back to life faster.
And how is it decided who makes a good candidate for each of the 3 different types that you mentioned?
Usually we look at what's going on inside the patient, and then also the patient and the patient's history. Someone who has a difficult access to the uterus, maybe who hasn't had children, or who had children years and years ago and they have small caliber opening down below. Someone who has adhesions or scar tissue inside, those would be perfect candidates for the Da Vinci system, because they wouldn't be a candidate for a vaginal hysterectomy or a laparoscopic hysterectomy. They would have to be cut open to get to that area. Now we could do the Da Vinci.
In regard to cost savings measures, a lot of people are wondering, I'm sure, does this get covered by insurance? And if so, is this less expensive for me than the traditional procedure?
It is going to be less expensive, and it is covered under the normal hysterectomy. So we bill the same amount for the procedure. Two of our hospitals in town have purchased the Da Vinci systems, and they're doing a lot of other prostate or heart surgeries with them. So the machine is already sitting there. So we just bill the same amount we billed without the Da Vinci system. But the benefit for the patient is going home that same day, sleeping in her own bed. So less of a charge hospital bill is thousands of dollars less because they're not staying there 2 to 3 days. And then they're back to normal faster. Some of my patients don't go back to work right away. They still have saved for 6 weeks off, and their work lets them have 6 weeks off, so they feel better, they feel normal. Some of my patients say, I want to be back to work in 7 days, 3 days, 4 days, and this is perfect for that type of patient also.
Separate from feeling better and having a quicker recovery, people are also concerned about scars. Is this a minimal scarring procedure versus the old-fashioned way?
Absolutely. The incisions are less than a centimeter, and so we call them dime-sized incisions, very small, and they are around the outside of the abdomen and near the belly button. And so scarring is minimal amount, minimal tenderness, and compared to the 6-7 centimeter C-section type of incision or up and down type of incision that goes all the way to the belly button.
Now, if someone was going to be having to have the open type of surgery, is there anyone who's having that type who wouldn't be eligible for some reason to use the Da Vinci?
Yeah, pretty much the only reason that we wouldn't be able to do the Da Vinci is if the uterus was so big that it came all the way up to the belly button, kind of like a 6-month pregnancy. In that case, the uterus actually comes too close to the camera, so we couldn't see because it's sitting right in front of us. But other than that, almost every other condition is a candidate for the Da Vinci.
What type of training is required to be able to use this type of technology?
It's a little bit extra training for the doctor, and I'm currently a proctor physician. Yesterday I was in Indianapolis training some physicians. Last month I was in Terre Haute, and so I've been asked to go around to multiple places in Indiana, Michigan, Ohio to train physicians, and so we're rapidly getting physicians trained. And it's a couple extra meetings, a couple extra seminars. It does cost a little bit of money to the physician, but after spending just a couple days to a week in the training process, when you do the first case on that patient who you would have had to open up, and in my experience, when I went over to see her in the recovery room, and I asked her, "Are you having any pain?" and she said, "Nope, nope." And I went back an hour later, "Are you having any pain?" "No, I feel pretty good." And then she comes to my office and tells me that she felt so good 3 days later. She's gardening, and she started feeling a little pain because she was bending over gardening too much. That was when I got all the reward, and I said, "This is definitely worth it. This is the right thing to do."
When looking at the advances that are taking place in medicine, I'm sure a lot of research had to go into developing this system. Can you tell us a little bit about what happened prior?
Sure. This system was developed for the military. It was developed under their secret projects budget, and the plan was to do remote surgery on the battlefield. So they would put this system on the battlefield. The doctors could be back at the base, and they could remotely do surgery. They're doing that, but not on the battlefield. They're doing it remotely from the base to another base. And so we've kind of been fortunate that it was developed by the military with some of the best engineers and technology, and then they opened it up to the private sector. And now it's a private company that's has continued the development on the machine, and it's just amazing what it can do for patients.
Now, you've mentioned that it can be used for a variety of other health-related issues as well, and is currently in our area being used for that. So are a variety of surgeries in our community taking place with the equipment? And if you could tell me a little bit more about just touching upon those surgeries.
Sure. One of the most common is the prostate, for prostate cancer. We're also having doctors use it for heart surgery, for colon surgery. General surgeons are starting to use it for some of the general surgery. Sometimes they've done a couple gallbladders with it. Appendixes, it's almost, you don't need to use it for the appendix. So we're seeing just a plethora of surgeries across the board. I had someone yesterday trying to develop it for complex pregnancies to try and help save pregnancies. So it's just phenomenal how well and what this is going to do for people.
Can you tell me about myomectomies?
Sure. Myomectomy is when we're taking out a fibroid because maybe a uterus has multiple fibroids, which is a growth, which could be from 1 centimeter to 10 centimeters. And this has changed the ball game on myomectomies. Traditionally, we had to open up a patient, remove those fibroids, and then fix the uterus in order for her to try to have children or keep her uterus because she doesn't want to have a hysterectomy. This has allowed us now to do that same surgery through these small dime-sized incisions, remove the fibroids, and she can go home the same day. And I had a patient actually who had this done. She had, I think, 20 fibroids, had those removed, and she showed up in my office last month pregnant. And it just is a wonderful, wonderful thing. And I was so happy to see her, and I know she and her husband were very pleased, and it's been a great success for her.
Separate from the fibroid issue, might it also have other uses in treating infertility?
Looking at the tubes, fixing the tubes, doing microscopic surgery on the tubes, because the ends of those tubes are very small. And so if we manipulate those too much, then we can damage them. With these instruments, and they're 2 millimeters at the tips, the doctors can do the microscopic surgery to help correct the tubes or fix the tubes and make a big difference for somebody.
We do have a caller on hold, so we're head to the phone lines where Rosemary's waiting for us. Hi, Rosemary.
Hi, how are you tonight?
Good, how about you?
Hello.
Hanging in there, still fat and sassy.
Would you like to share your question with us?
Yes, when I was younger, the doctor that treated me, she said she was going to give me a partial hysterectomy, but it turned out she gave me a complete hysterectomy. Now, by doing that, do I still need to have Pap smears taken?
Thank you for the question. The partial hysterectomy is the uterus only. Complete hysterectomy, and this is more the layman's terms as I talked at the beginning of the show. Complete hysterectomy, she was referring to taking out the uterus, cervix, and the ovaries. And we do recommend Pap smears after a complete hysterectomy, which is a swab from the top of the cuff of the vagina where the cervix used to be, because we can see some abnormal cells there. So I would recommend checking with your doctor to continue that process. Now, once a woman's reached 65 or above, there is a possibility you may not need that Pap smear anymore, but you still need the annual exam to make sure that there's no growths or abnormalities inside the abdomen.
Thanks for your call, Rosemary. Did you have any follow-up questions?
No, that's fine.
Okay.
Some say yes, some say no, so I'll go with the yes then.
Have a good evening, Rosemary.
You too. Thank you. Bye-bye.
What about follow-up procedures after a hysterectomy? As Rosemary mentioned, are there any things that people should not be doing?
Yeah, that's a good question. I hear this a lot, and a lot of people think that without a Pap smear they don't have to come into the doctor. And the Pap smear just refers to that swab of those cells. So it's still very important to come in once a year for the breast check. For the regular check, you may need a cholesterol check, a thyroid check, listen to your heart and lungs, especially feel for the ovaries or any abnormalities, masses, or cysts that could develop. Even colon cancer checking, we check for that. So annual visits is extremely important.
Talking about cancer-related hysterectomies, can you talk a little bit more perhaps about what other treatment might also be required and working in conjunction perhaps with oncologists in an instance like that?
Fantastic. Yesterday I was actually training an oncologist on how to use the Vinci system. So I was training him on the benign hysterectomy, and he's also learning the second part of the procedure is to do lymph node staging with the Da Vinci. So now he's going to be able to take those patients where he had really large incisions. He's going to be able to take the cancer out with the Da Vinci and check the lymph nodes with the Da Vinci, which shortens the hospital stay by 3 to 4 days, go home the next day, and tremendous decrease in pain and or complications. I didn't talk too much about bleeding, and mainly because we don't have any now. The Da Vinci, we hardly lose any blood at all. That's part of the reason patients feel good, because they're not tired and fatigued. We lose usually less than a tablespoon of blood with the Da Vinci, whereas with an open case we're usually looking at about a cup full of blood. And it's a big difference on how you feel afterwards.
We have another caller on the phone lines. This time it's Arlene. Hi, Arlene.
Hi there.
Hello.
Go ahead with your question, please, Arlene.
It's similar to the last question. I've had a full hysterectomy, but the doctor left both ovaries. I'm wondering if I still need to have a yearly Pap smear.
Yeah, Arlene, that is a follow-up question that helps me out. It kind of helps us to tell you about the difference in the layman's terms and the medical terms. You've actually had a regular hysterectomy, which means uterus and cervix are removed, but he kept your ovaries. So that the layman's terms would be partial hysterectomy also, but hysterectomy refers to uterus. So yeah, you still need to have the annual exam where the doctor's going to check your ovaries to make sure that those are normal and those are okay. And the Pap smear is that swab, and you can talk with him or her about whether you need that Pap smear every year, every 3 years. I usually recommend to my patients every 3 years and to definitely do the bimanual exam to look at your ovaries.
Arlene, is there anything else you wanted to ask?
No, that's it.
Okay, thanks. Sarah, you're up next. Sarah, if you're there, I'd want to share your question.
Yes, I do. I have a question about anesthesia time. I was kind of wondering about, is the Da Vinci worth using anesthesia-wise and being under? And then my second part of the question was, how big of the opening do you have to enlarge to take the uterus out from the normal opening you'd have with the Da Vinci?
Yeah, the anesthesia time is based on the time the surgery takes. It's taken about an hour right now to do a routine Da Vinci hysterectomy. So that's about an hour being asleep. Sometimes it takes just actually using the Da Vinci system about 35 minutes. The other 15 to 20 minutes is cleaning you off and making you sterile while you're asleep, and then waking you up takes a few minutes. And we do need to use anesthesia for it because when you're asleep, we do insufflate the abdomen with a little bit of air so that we can see, and it's hard to breathe if you're awake. So we do put you to sleep, but about an hour is the average time. Tell me your second part of the question again, please.
That was, when you take the uterus out, how much bigger do you have to make that opening?
Right. Usually we can take what we do is we separate the uterus from the top of the vagina and the cervix, just like normal, just like we would do in a regular open hysterectomy or vaginal. And usually it'll fit through the vagina, and we'll kind of just push it out down below while we're inside doing the case. If that is, the uterus is too big for that, we have a little special machine that'll take it out through a 1 centimeter incision, kind of like an apple core machine. It'll take apple cores out of the middle of the uterus until it's all out through that small incision. So we don't make a bigger incision to get it out.
Is there anything else you wanted to ask, Sarah?
No, thank you.
Okay, thanks for calling. If we could talk about prolapse and what that is and how Da Vinci can help with a prolapse.
The Da Vinci is a great tool for prolapse. There's a couple ways to do prolapse surgery, and prolapse is when the bladder and the rectum or the vagina and or uterus have kind of descended down in the vaginal canal, usually as a result of children or large children or constant chronic lifting throughout life. Many times it is related to your genetics. And the Da Vinci can help by transforming one of the large surgeries into the minimal invasive surgery with small incisions, and it can help us take a graft from the vagina to the back of the sacrum to lift things back in place. It works tremendously well for that, so that people can get back to life and not have that pressure and pain and discomfort from the prolapse that's coming down.
Looking into the future with this type of technology, what other advances can you perhaps imagine happening because of this style of surgery?
I think this is kind of opening the door even further for truly that Star Trek type of surgery. That is going to be, everything's going to be minimally invasive. The large incision is going to be a thing of the past. I think taking the old surgery where we put our gloves on and we put both of our hands in the patient and we use these big retractors to make this huge incision, I think that's completely going away in just a matter of years. I think all doctors are going to have to learn how to use these minimally invasive tools to keep up with what the patients are saying, is that, hey, I don't want the risk of the large incision. I want the quicker anesthesia time. I don't want to bleed a lot like they used to do, and I want to be back to normal soon. And that's what I think the future is. In addition, they are currently working on robotic surgery devices that we can actually drop inside of an incision and control them from the outside. And so that's already on the horizon. So I'd be able to sit next to the patient and somehow look inside with these little robotic instruments, and they're kind of walking around and they're fixing the problem. and that's probably only a few years away.
When a patient knows that this type of procedure exists, I think there's still some hesitancy for some individuals to question a doctor or challenge a doctor. There's still that doctor as authority figure. How does one go about becoming more informed, becoming your own patient advocate, and talking about options and seeing that if you are a candidate for options, that you get the options that you desire? Because I still think that there is a fear on some women's parts to challenge.
Absolutely. The internet has been a great equalizer. And there's a lot of sites on the internet. You could just type in Da Vinci Surgery or the company Intuitive Surgical, and a lot of things will pop up. And women are online talking, and there's groups on, and there's blogs online where they type comments. And so I'm finding that a lot of women are coming in and saying, hey, I checked online about this. I saw your name on there, and I saw the name of so-and-so and so-and-so. I want to learn more about it. And word of mouth. A lot of women are talking to their friends, and I encourage them to tell their friends if their friend says, hey, I got to have this huge incision tomorrow or next week, say, wait a second, I heard about this new procedure, and maybe this will save you a lot of pain and heartache. So go research that on the internet. Even my 80-some-year-old grandmother's on the internet. So I think most people understand it and have access to it, and they can get that data to kind of just at least hand it to their doctor. And maybe that'll help take away some of the fear. Just hand them that. Don't tell them anything. Say, hey, what about this?
I know that a lot of times that people are resistant to change, that sometimes something seems experimental or too revolutionary. Are there other places in medical history where something seemed like that and now we take it for granted and that's just the way it is, that you might be able to do a correlation to?
Oh, for sure. C-sections, keep it in my field. Used to be years and years ago, before we had antibiotics, a C-section could mean death, because we didn't have antibiotics to treat the infections that occurred, and we didn't understand sterile technique. And so there was a fear of C-sections, that if you couldn't deliver the baby naturally, you could die. And so that's changed, where nowadays when you hear someone's having a C-section, you think, oh great, you don't think about any problems like that. You think, well, she'll have the baby out at such and such a time because that's when the surgery is going to be. And so that's one place that we've had a dramatic revolution and change, just like this is doing to large incision surgeries to minimally invasive.
We have another caller on hold. This time Chris is up. Hi, Chris.
Hi, I'm wondering if it's necessary to have an enlarged uterus removed.
Yeah, Chris, I have a little hard time hearing you, but I heard you say, is it necessary to have a large uterus removed? And I usually tell patients, if it's causing you problems. If it's not causing problems, and the problems would mean bleeding, cramping, pressure, pain, discomfort, sometimes even back pain. If it's not causing any of those, then you may not need to have anything done or removed on it. I would suggest you follow that with your doctor. If it is causing you any of those, then consider doing something or planning for something in the future. I think quality of life is very important, and we never know how much time we have left. And I do have women who will put up with problems for years and years and years, and then things will happen, and we'll have it fixed, or we'll have a surgery, and they'll say to me, I wish I would have done this years ago. Some of that is fear, some of that's anxiety, but just talk to your doctor, and you guys can talk about options and figure out what's best in your case.
Chris, if you're still on the line, did you have a follow-up question?
No, thank you.
Thank you. Bernie, you're up next. If you're there, Bernie, go ahead.
Yes. I just wanted to tell the doctor that he did a complete hysterectomy on me about 4 years ago, and everything just turned out beautiful. And one thing that I appreciated him doing is praying with me before surgery. And I want to thank him very, very much. That was a godsend.
Well, thank you. Thank you very much, Bernie. You're giving me chills right now. And I think the prayer that I say before surgery, and you said with me, is very important. And I know I can use a little help, and I think we all can use a little bit of help. Thank you very much.
Thanks for calling, Bernie. We have about a minute left in the show. If there's anything you wanted to add in closing.
No, thanks. I think we're revolutionizing women's care. We're putting the patients first. I think it's the right thing to do, and I hope patients continue to talk to their doctors and their friends, and I'm going to keep teaching doctors, and we're going to do the right thing, and we're going to get patients back to life faster.
And again, if people want to learn more information about this type of procedure or hysterectomies or myomectomies or any of the things that we talked about, are there some good websites perhaps or good books, any place that they can turn to for information?
Intuitivesurgical.com, or just go to Google and type in Da Vinci System.
Okay, I want to thank you so much for joining us this evening.
Thank you.
And definitely want to thank all of our viewers and callers who participated in tonight's show. We do have another Healthline program coming up next week. It's going to be What is Plastic Surgery? That's with Dr. Brian Lee, so I encourage you to tune into that. You are watching PBS 39. Thanks for joining us, and have a great evening.